Hello everybody. Over the next few minutes we will talk about how we might integrate next generation imaging, whole body MRI or PSMA PET-CT for treatment monitoring of men with metastatic hormone-sensitive prostate cancer. These are my disclosures. Now, we know there's a spectrum of disease as far as hormone-sensitive prostate cancer is concerned, and this is shown over here. We have non-metastatic disease here on the left, synchronous metastatic disease occurring at the time of presentation that can be of low volume or of high volume, and metachronous metastatic disease that occurs sometime after the primary tumor has already been treated, and this can either be of low volume or of high volume. We know that these states have different prognoses. So a high volume synchronous metastatic disease has the worst prognosis, and low volume metachronous disease has a better prognosis. Now, because of this prognostic implications of high and low volume disease, there are different treatments for high and low volume disease, and you can see if you have low volume disease, generally speaking, you would tend to get a doublet therapy with then androgen deprivation treatment and an androgen receptor pathway inhibitor of some sort, and usually radiotherapy with a radical intent. If you have high volume disease, you would get a triplet therapy, that is to say ADT, docetaxel, and an androgen pathway inhibitor if you are chemo fit, but you could even get a doublet in this instance, and pelvic radiotherapy would be for palliative purposes. Once you fail these treatments, of course, you go on to the next lines of treatment, in this particular instance for castration-resistant disease. So what we've said is that these androgen pathway inhibitors, the backbone is really these ARPIs for both low and high volume disease, but we know that not all patients benefit. About 20% of patients don't have a durable benefit, and in some patients we see a rapid re-emergence of the disease. And I just wanted to show you this last bit first. So here's a man who's had a low volume disease to start with. You can see a PSA is not very high, 8.3, does very well in this particular instance with docetaxel, but then rapidly you can see that he progresses, and then when he started on an ARPI, you can see he just progresses very rapidly with liver disease, bone disease, and nodal disease. So why does this happen? Well, the upfront use of a highly effective therapy means that the cells that you are going to kill will die, and the remaining cells will become more aggressive, and there will be loss of tumor suppressors, activation of oncogenic drivers, and these lead to a progressive visceral disease progression with a very heterogeneous biology, as in the example that I've just shown you. So with these ARPIs, what is the durability of response? In other words, what percentage of patients are no longer benefiting after, say, 2 years? Well, it turns out it's about 1 in 5 men will not have a durable response beyond 2 years. So, and you can see that here. You can see that in the ARCHES study with enzalutamide, you can see about 26% of men were no longer clinically benefiting after 2 years. If you look at the ENZAMET trial again, looking at enzalutamide, you'll see it was 20%. And if you look at the TITAN study, which looked at apalutamide, again you can see about 20% did not have a durable benefit beyond the 2-year time point. So what's wrong with using PSA for assessing response? We know that these androgen pathway inhibitors also suppress the production of PSA, so you can get instances where the PSA does not reflect on the tumor burden. In other words, there's a discordance between imaging response and the PSA response, and I've just shown you a couple of examples here. So in the Archer study, for example, about 2/3 of men who were progressing on this trial did not have PSA rises that matched the progression criteria. In the Enzamet study, about 1/3 of men who were progressing radiologically did not have PSA progression. And this speaks to this disconnection between what is happening on imaging, where you can see progression, and the PSA, which may not reflect that. Now, it turns out that the PSA decline, not progression, but decline, is actually quite a good marker for a positive response, and this is shown by all of these studies. So a PSA below 0.2 around about 6 months after starting treatment, in fact strongly predicts treatment efficacy. And this was looked at recently in the Titan study with looking at apalutamide. And again, they made a similar observation. They said men not having a response within 6 months did not benefit from the use of apalutamide. And if you looked at the 4-year time point, you'll see that only the men with the deepest response, in other words less than 0.02, these men here, had a sustained long-term response. Men who had a PSA between 0.02 and 0.2, here you can see that out at 4 years you can see that about 70% of men are in fact failing. But the interesting thing is, notice how the ADT, the placebo plus the APA, they come together at this time point. So in other words, when we think about the 4-year time point, what we're saying is that it's giving the apalutamide is as good as giving the ADT. So patients not reaching this profound less than 0.02 by 6 months, in fact, were doing just as well as patients who got ADT alone and achieved the same level of response. So we can start to think about how we might start to look at this response at 6 months to do next generation imaging to see what is going on in these men. So if you did next generation imaging and you had a good response, less than 0.2, you'll see the majority of times patients were either completely responding or partially responding on an MRI scan. In other words, it faithfully reflected response. However, if you did not reach the level of 0.2, in other words, it might have gone down, but it didn't go down to that 0.2 level. If you did imaging in these patients, in fact what you'd find is about 1/3 were in fact progressing. Here we go. You can see that here. So 21 men did not reach this nadir, and when you did whole body MRI, you can see that in fact they were progressing and they had a higher risk of death. So that is interesting. So what we're saying is, if it's getting down to less than 0.2, then the MRI is going to reflect what the PSA is showing. But if it doesn't go down to 0.2, then you may in fact be progressing, which speaks to the value of using next generation imaging. So next generation imaging can overcome some of the limitations of CT scans and PSA for monitoring response. It can detect persistent active disease, which is missed by PSA declines alone. In other words, it can look at the primary tumor, it can look at metastases, the sites, the location and the viability. It can certainly identify new sites of disease, and in fact it may enable you to do biopsies for molecular diagnostics. So let's have a quick word about this. So here are the criteria that one might use with whole body MRI to identify areas where there may be viable tumor cells. So if you had a hyperintense high V value signal, a low ADC value, and a low fat fraction, and you were to biopsy that, what you would notice is that the positive predictive value of these three things together to yield cancer cells that were viable is about 91%, which is a very high specificity. So the specificity is about 80, the positive predictive value is 91. So if you have each of these criteria and you biopsy that, you are going to have viable tumor cells underneath that biopsy site. So you can see how you can use this type of information to yield tissue samples that may yield actionable mutations. And here's an example. So you'll see high signal on the high B value here and a low ADC. This was biopsied, yielded a BRCA2 mutation. The patient went onto a PARP inhibitor. You can see the ADC generally increases, and this means response, but we've discussed these in other lectures. But you can see what happens later. The patient has a high signal intensity on the contralateral side and a low ADC, and when this was biopsied, you can see the BRCA mutation was reversed. So what we're saying is that next generation imaging directed biopsies can yield predictive actionable mutations. And I just showed you an example of a BRCA mutation that was found on a biopsy. But if you saw losses of P10, RB1 loss, or P53 mutations, this patient might in fact be treatable by carboplatin and taxane. If you saw P10 loss, for example, an AKT inhibitor may be appropriate. If you had a MRSI high, then you may be a candidate for immunotherapy. So you can see how next generation imaging is driving that decision making. And of course, if you use PSMA PET-CT as your chosen next generation imaging technology, then you could profile that patient for lutetium PSMA therapy. And here is an example. So here's an example of a man who has an FDG PET, a PSMA PET a couple of days apart. And you can see FDG is negative, PSMA is positive. This profile would predict for response, and you can see how well he responds to lutetium PSMA PET. So just showing you how you might use next generation imaging molecular diagnostics, in this particular instance by imaging rather than by biopsy, to predict that somebody might in fact respond to treatment. So how do we think about utilizing these technologies to tailor treatment monitoring of men with hormone-sensitive prostate cancer? Well, one of the things we said is that if you have a suboptimal response, we know some of these patients are progressing. So we've also said that next generation imaging can identify these men. So if you see this early on, you might want to think about treatment intensification. If you see this later on, you may think about substitution. So either as intensification of treatment or a treatment switching. If you have a patient who has a sustained and deep response, in other words, is responding, these patients, you should do next generation imaging because it would enable you to undertake some sort of consolidated radiotherapy, even if they had high volume disease to start with. So you could consolidate the prostate gland, you could consolidate the treatment of lymph nodes, or if you had oligometastatic bone disease, you could certainly boost those areas and then continue to use the ARPI as your treatment backbone. And I just wanted to show you an example. So here is a 60-year-old man being treated with apalutamide. What you notice is I've just put up some images of the pelvis at two different locations, before and after treatment, and you can see what type of response. So 131 going to 0.03, so a good deep response to apalutamide treatment. And you can see the lesion decreases in signal intensity, the fat returns to the metastasis. In other words, this is healing. But if you look at the pseudo-CT, which will in fact just reflect the CT if I'd done it, you can see that the CT really doesn't change. If you look at this lymph node here, for example, this lymph node's done very well, but there is a small residual lymph node where this lymph node was, and here's the fusion of this image with this image, just to make that very clear. So there is a small residual lymph node in the right obturator region. Now you can use this information in this patient who has done very well with apalutamide to boost these residual areas. So here is a part of the radiotherapy plan showing how this node here was boosted, this node here was boosted, and remember this lesion here? This lesion was also boosted, and in fact there was another deposit in the right pubic bone that was also boosted. So if you have oligometastatic disease, you can begin to adapt and use these treatment plans to consolidate these areas of residual disease, and then to continue using the apalutamide in this particular instance into the future. So here is the actual proposal shown as a schematic. So you can see that the baseline use of next generation imaging would be for distribution of disease, for prognostication, for treatment planning. Then the patient's treated with an ARSI. You do 3 monthly PSAs. This point here is the landmark. So a 6-month landmark, or the nadir. And if you do the PSA at the nadir and it's less than 0.2, you know this patient's going to do well. So you just carry on looking at this guy. You can either do a CT for follow-up. We tend to do whole body MRI scans, and that can go on to the very end if he maintains a response, and then use next generation imaging for planning the radiotherapy and any areas that you may want to boost because there's residual disease, what I've just shown you. But if you do not reach that deep nadir, or if you have an rising PSA, then you want to think about treatment switching or treatment intensification. So clearly intensification would be up here early on. Treatment switching would be for castration-resistant disease, which is when the PSA rises despite the backbone of ARPI. And remember, it is these patients here who would benefit from histological or blood for tissue sampling for actionable mutations. So just to conclude, if we start using next generation imaging and PSA together, we can improve the accuracy of response assessment in men with hormone-sensitive prostate cancer. It looks like this nadir PSA, or the 6-month landmark, really is important, and the use of next generation imaging for the suboptimal responders at that point is really critical. So what we're saying is this integrated approach has great potential to improve treatment decisions, be it intensification, treatment switching, selection of targeted therapies, consolidation of pelvic radiotherapy, and even metastasis-directed therapies. If we start using PSA kinetics, next-generation imaging, and molecular profiling, then we have the great potential to pave the way for more optimized decision-making in these men with hormone-sensitive prostate cancer. I hope you found this recording useful as you think about how you might want to use next-generation imaging for these types of patients that you are also seeing. Thank you very much for listening.